welcome to the Aaron Warner podcast on iCode Media. I was running again this week and listened to another fantastic podcast episode on the Chris Wolfe podcast, this time with Dr. Lisa Greene. The two of them discussed a contour prism, specifically the Neurolens, and the effect that it's had on their practice. Fantastic episode. I strongly recommend you go and listen to it. I've linked it here in the show notes so you can go there. But I want to share some of my reflections that I had and recorded on the run. Again, kudos to my Oakley Meta Vanguards. I know you may think they sponsor me by how much I talk about it. They do not, but if they're open to it, let's have a discussion. So while I was listening to Chris and Lisa's discussion, I reflected on the experience that we have had in our practice with Neurolens. We've had it for quite some time. In fact, we started with the box, and I like to refer to it as the box, and then moved into the headsets, which has been a huge upgrade, both for efficiency, patient education, and just overall team understanding and experience with binocular vision and the Neurolens product specifically. But before we get into that, I just want to share a bit of background on me and why this matters to me. So many of you may know I'm a fifth generation optometrist, and binocular vision has always been part of my lens, no pun intended, part of our focus. My grandpa was heavily focused on binocular vision, and I believe there's still a room at Marshall B. Ketchum, formerly SCCO, that is named after him because of the work that he did with binocular vision in the school. My dad carried it forward into practice. As we've expanded our scope of practice, he brought in more quote unquote medical optometry. To me, I don't think there's a difference between regular optometry and medical optometry. I think it's just optometry, and we should all be practicing to the full scope of our licensure. But I will, for sake of discussion, refer to it as medical optometry. But we didn't lose focus on the importance of binocular vision and healthy vision. And that's really shaped how I practice, how the practice continues with our associate doctors and our full team. See, it's not just about seeing clearly for us individually with your eyes. It's about the whole system working together. And that's what I tell patients, that my job is to make sure that the right eye and the left eye are both seeing well, and to make sure that both of them are working well together. Because if you have two high functioning individuals, but they're not working well together, that can create problems. So we want the whole thing working as one. And that's really where binocular vision plays a role in all of this. I talked about our scope of care and being optometrist. I would identify us as primary care optometrists. We're not necessarily binocular vision specialists in the sense that we don't do vision therapy in the practice. I did when I first came out of school for a little bit, and then realized that there were other doctors that were more capable and had the capacity to do binocular vision therapy in their practice, and vision therapy in the practice. And so we stopped doing VT and referred to them, created great referral relationships. Two of my children went through vision therapy sessions with a private practice optometrist that was close to us. And I think it's important that as optometrists, we find what each other does well and refer as necessary. So for us, that is part of our process of taking care of those patients. We also use a lot of prism in the practice. For me, it was always normal how much we use, but as we get externs that rotate through, frequently we hear that we use a lot more prism than they've had experience with in any of their other rotations. So maybe it's a lot, maybe it's not, I don't know, but it certainly speaks to the fact that we are addressing and looking for binocular vision issues and how we can correct those. Chris and Lisa had a fantastic discussion about why patients may not bring their complaints and share with us their symptoms of headaches, of asthenopia, and I think Lisa really put it well in part of the discussion when she said that she was just trying to survive the afternoon, the back half of the day, and I think that Chris and Lisa covered most of, if not all, of the reasons why patients don't bring those to us. Maybe they perceive that we won't care or we're not going to do anything about that. Maybe that's been their experience in the past. They've been blown off. Maybe they don't realize that's eye related and vision related. And so they don't bring it up because they don't see us as anything beyond glasses and contacts. I think that the other reason patients may not bring these up, in addition to what they covered, is that patients have just established a new normal for themselves. Being uncomfortable, having headaches, trying to get through the end of the afternoon, the end of the workday is just normal. Going home and being exhausted, not feeling good, not having that extra pep in your step is normal for them. And so if things are normal, there's no reason to complain about it because there's not a problem. And that can be a scary place to be. So I remind myself and I remind patients that normal doesn't always mean healthy. Normal just means that your baseline, and your baseline may be an appropriate baseline, or it may be something that highlights that there's a problem. One of the key symptoms or normals that Lisa addressed in the discussion was an avoidance of reading. And she talked about asking her patients, if they read, if they like to read, and have that discussion, which I 100% agree with. I think that's a very important question to ask, especially school-age children all the way through college and secondary schools. I also think it's an important question to ask of adults. Now, I don't ask adults if they like to read. I ask adults what they like to read. And I've just found that question solicits a much better response than do you like to read? For two reasons. One, I do like to read. And so when asking patients what they like to read, often they'll give me some great suggestions that I will write down and go back and read. Other times, though, it'll give me a real sense of how they feel about reading based upon their response. Sometimes I get a pretty strong emotional response that they don't like reading and never have. I've also noticed that those patients tend to be the ones that are a little bit bigger in life and a little bit louder and like to be outside and doing things. And I suspect that's because their natural binocular posture is a little bit more exo, a little bit more, big and broad, pointing out to the world as opposed to pointing in and being able to sustain that convergent posture while they're reading and doing close work. Haven't done any studies with it. I've just kind of noticed that about the personalities. But I do ask them, either if they like to read, if their children are still in school, and then adults, what they do like to read. And that's been pretty significant as to identify any symptoms of avoidance. Speaking of symptoms of avoidance, it doesn't just have to do with binocular vision issues. I find it as well when patients say they don't like to drive at night. I ask that question. Do you feel comfortable driving at night? Do you like to drive at night? Do you drive at night? And somebody who says no, I ask more questions. And if it's a more recent development, it points to something. Maybe it's a dark adaptation issues that we can look and evaluate and test for. Maybe it's advancing cataracts. But anything that has changed, especially that involves avoidance now, is something that we look at. So we try to identify those binocular vision issues and solicit the symptoms from the patients. Neurolens does a great job in their questionnaire that my techs work through with them of soliciting some of those questions and then rating them. We also test, and testing for binocular vision has always been part of our comprehensive wellness exam. Not the super detailed testing, but we want to screen enough to make sure that we've really evaluated and tested the binocular system just enough to make sure that it's doing what it needs to do for the patient. Now that with the Neurolens headsets in every exam lane, it makes it really easy and really consistent. So our workflow at Werner Optometry is that we have a Neurolens headset mounted on the wall in each of our exam lanes. When the technician, after pre-testing, brings the patient into the exam lane to get a more detailed chief complaint, to set up the exam room, pull up the images that we've taken from our OptoMap screening retinal images and other things, set the phoropter and whatnot. That's the time that they'll put the headset on the patient and have them run through the test. That's when they'll do the questionnaire. And what this has done for us is a couple of things. The first, it eliminates downtime, that quiet time, the patient sitting alone in the room, either staring at the clock or playing Candy Crush, waiting for the doctor to come in. And for patients, that feels like an eternity, even if it's just a couple of minutes. So it eliminates that because they're working with our technicians, hopefully having a very positive conversation, or certainly having a positive experience going through the Neurolens test. We're getting consistent data, binocular data collected on the patient, so that I don't have to manually take those tests in the phoropter if I don't need to. I can certainly double check it if I want, but I tend not to need to. The patient also has a really neat conversation with our technicians about why we're asking about headaches and strain and whatnot, why we're measuring for binocular vision, the importance of binocular vision, and then highlighting even real briefly the results of the Neurolens test, where it shows where proper alignment may be and where the patient's alignment is. It's a pretty rudimentary but very simple to understand image, and I think that's pretty powerful when it's so simple, highlighting it to a patient. If they do indicate that there's a problem because the scores are high or there's a misalignment, the technicians will tell the patient that that's something that they want the doctor to make sure that they review with the patient, so they'll highlight it to us, really reinforcing the importance of why we're doing what we're doing, and teeing the patient up for that experience. I talked before about how patients kind of normalize whatever their baseline is. Sometimes that's normalizing a dysfunction and not realizing it's a problem. This hit home for me a long time ago, but the first time in the practice, I really started putting patients into computer glasses. I don't know what the impetus was, but we started using computer progressive designs a lot more. And so I got a pair for my mom. My mom had always suffered with migraines. Migraines are run in the family. And this was before Neurolens was even available, but I put my mom in a pair of computer glasses, and she said, "Hey, I don't think I like these. I have to sit funny with them." I thought that was odd. She said I had to sit funny with them. I said, "Well, show me." So we put her in front of the computer, and I put her in her computer glasses, and she sat good posture up and said, "Look at me. Don't I look funny?" And instead of immediately correcting and arguing with her, I said, "Well, put on your other glasses. Let me see what I'm looking at." Because again, comparison is important. So she put on her everyday glasses that were standard progressive lenses, distance and near. And she had this weird S-shaped head tilt kind of off to the side. Clearly her system had gotten used to trying to find just that right focal length through the glasses to read her computer screen. And she said, "See, this looks normal." And when I had the other glasses on, I didn't look normal. So I chuckled to myself. I pulled out my phone. I took a picture of her with both glasses, showed her the pictures, and said, "No, you have just normalized not being normal with your old glasses. So it's going to take some time to adapt to sitting properly, but it's going to be better." And it certainly was. She's now in Neurolenses because they've helped, and it's greatly reduced her symptoms. So we see progress over time. But it reminded me that, again, patients have normalized sometimes dysfunction. So we're really not creating discomfort in them. We're exposing it and helping them see it so that we can make it better, just like we do with glaucoma or ocular surface disorders and dry eye and whatnot, right? Sometimes they're very symptomatic, and a patient will come in and say, "Hey, my eyes are red, my eyes feel dry." That's easy. I don't think I've ever had a patient come in and say, "Hey, I think I have glaucoma." They may have, had a fear of it because a family member went blind, and they wanted to get checked, but nobody said, "Hey, I feel like I have glaucoma." That's something we have to see and uncover during the screening and then the diagnostic test for them. Sometimes the same thing with dry eye. Right? Patients' eyes have just been so uncomfortable for so long. That's their new normal. And we have to tell them that it's not normal that your eyes water all day long. That it's not normal that you have to constantly put in drops. They think that's the way it is. So we have to look for those signs and symptoms and not just wait for patients to tell us. At least that's my experience. The Myopia Collective. Cooper Vision and the AOA have partnered in a groundbreaking initiative to change the way optometrists in the U.S. treat children with myopia. The purpose of the Myopia Collective is to rally the profession of optometry and its allies to interrupt the status quo and elevate the new standard of care for children with myopia. Every individual is encouraged to become a member of the collective. By joining, you commit to taking action to help slow the progression of myopia in children. You'll receive updates and information about the collective and its work in the fight against myopia, gain access to educational opportunities and resources offered by the collective, and hear from change agents, the ambassador optometrists selected to serve as advocates for community and policy change that facilitates the mission of the collective. Scan the QR code or click on the link in the show notes to join the collective today. In the past, our focus revolved around prescribing MacuHealth or MacuHealth Plus to patients at risk of macular degeneration, while also recommending it to collegiate and professional athletes for enhanced contrast sensitivity in sports performance. However, this year's introduction of the Life Meter has been a game changer. The Life Meter revealed a concerning truth. Many of my patients have alarmingly low skin carotenoid levels, indicating potential deficiencies in essential body tissues like the retina and brain. Supported by over 30 peer-reviewed publications, Life Meter's accuracy, consistency, and effectiveness has been demonstrated across 2,000 subjects with diverse backgrounds. With this newfound insight, I can now have meaningful conversations about carotenoid levels with all of my patients, even those who may seem outwardly healthy. To learn more about this empowering technology, feel free to contact your MacuHealth representative or click on the link in the show notes. Together, let's optimize patient care and elevate their well-being. I also think that when we do that little bit of extra questioning and asking and brief education, patients appreciate that. That's why they're coming to see us. Right? They want to see better. They want to feel better, even if they don't know exactly how to put it into words. So I looked back and historically of what we've done with Neurolens in our practice. And the data was pretty interesting. About 7 to 8% of our total prescriptions were Neurolens prescriptions. It's fluctuated. Sometimes months has been well into the double digits. Sometimes it's been a little bit lower, and that's okay. Actually, that's expected. And the reason that's expected is because we don't have a target for how many Neurolenses to fit in our practice. We have a mandate that we believe that we recommend products when they'll actually help. One of our core missions is recommendations that you can trust. And so we don't recommend products because we can gain financially from them. We don't recommend products because we want patients to buy something from us. We recommend products and services that we believe are going to make a difference for our patients. And so we tailor those recommendations. Because of that, we have a very low non-adapt rate on our Neurolens. Very, very few. I can't remember the last time we had somebody return it for buyer's remorse or because it didn't work. We may have had some needing to adjust slightly, but not a return. I don't want these. Let me go back to just traditional prism. And I think that's because my team and my doctors do a really good job of educating the patients, not taking a ton of time doing it, but doing a very good job of clearly educating patients what they're getting, why they're getting it, and even talking about the additional cost compared to what traditional glasses would be, mostly because managed vision care often doesn't have a benefit for the Neurolens technology. So we set proper expectations. We have those honest conversations, and patients appreciate that. And our success with them, their success with the Neurolens is very high. Now, I've also had discussions with my colleagues, and Chris and Lisa addressed this very well and comprehensively on their discussion. So I'm not going to rehash what they talked about, but we talked about the lack of large randomized control trials in regards to Neurolens. And that still matters. But the reason that we brought the technology into the practice when we did was because there was other evidence that we just couldn't ignore. Now, there's since been published some additional headache evidence and different studies that, again, Chris and Lisa really did a good job of talking about, and I would recommend you go read those. But when we brought the technology in, that wasn't available. What I did see was a significant amount of case reports. I talked to a significant number of my peers, and really saw patient outcomes firsthand. And we looked at those and said, I can't ignore these. Now, they're not the top of the clinical study pyramid, but they are evidence that we can look at and gain some insight and some information from. And part of our goal as optometrists is to make sure that we are taking care of the patient with the tools that we have available to us. And so if we see positive experience and positive case reports, we have to look at it. And for us, it was strong enough to say we needed to bring this in and offer it where appropriate to our patients. What we did is we started with our worst case symptomatic patients, because I think that's what we do as optometrists, is we say, hey, something's going to work. Let's try it on the person that nothing else has worked for. And we saw some significant relief in some of those patients. And others, we saw just some improved comfort. Right? It wasn't the tears crying, I'm happy, you've made life change. This is life changing for me, but it was positive comfort. And that's important, that everyone can have a little bit of a different response. What we saw was that it was positive, right? Not every patient had a dramatic response, but every patient that we tried it with had a positive response. We did try it with our full staff, and some of those we had a neutral response, and that's because they didn't have really binocular vision issues, and that's okay. But the majority had positive responses, and they understood why we were recommending these where appropriate to patients. By the way, we also try to have our staff have hands-on experience with all the technologies that we do in the practice, whether it's a new Verilux lens, a new Crizal anti-glare treatment, IPL, LipiFlow, ProCare, amniotic membranes, whatever the case is. We try to have them have some exposure to it, maybe not themselves, but at least within the office, so that they can speak to patients from a place of experience and education. So we continued with Neurolens because we saw that consistency of positive outcomes, and that was just reinforced the more that we offered it to the correct patients. So it made a difference for us, and the data, I believe, continues to come out showing that it is a strong tool for helping patients reduce symptoms that are caused by binocular vision issues, and that contoured prism is pretty significant as a treatment to help reduce those symptoms. So I want to close with highlighting something that Chris kind of closed that discussion on, and that's the urgency and the importance of acting. Optometrist doesn't have a problem acting with urgency for glaucoma or moderate to advanced macular degeneration, contact lens misuse, right? We're going to have a conversation with our patients about these. A patient who has glaucoma isn't coming in for follow-up and isn't taking their drops consistently. A macular degeneration patient who is using tobacco and smoking. A patient who's abusing their contact lenses and sleeping in them, not taking them out for a significant amount of time. We're going to have conversations with these patients, and rightfully so, we should. Oftentimes, I think we underact, and our urgency isn't nearly as strong for other things like headaches, eye strain, asthenopia, dry eye, functional vision issues. But I think we need to reconsider that and have as much urgency for these things as we do for the other diseases that I talked about. So if symptoms are real, if it's impacting daily life, and if it's potentially vision related, we need to act with urgency. It's our duty, I strongly believe, to address these things with our patients. And when we do that, we also need to remember, as Chris discussed in the episode, to document appropriately. Right? Document the diagnosis. If it's convergence insufficiency, document the symptoms, the asthenopia, the headache, whatever the case may be, and why that we're making the recommendation that we have. This is important for continuity of care. It's important for defensibility legally, but just when another doctor says, hey, why did somebody put you into Neurolens? Why did, maybe a patient moves cross country and that doctor says, oh, you're in a Neurolens. Why? They can go back and read the chart and clearly see why the patient was prescribed the treatment they were prescribed. Not just for the doctor, for the patient, and for anybody looking at that. So it really is just good medicine. It's good chart documentation. So I want to give a big shout out and kudos to Chris and Lisa for a fantastic discussion. Again, if you haven't listened to it, I strongly recommend you do. Please click on the link in the show notes and listen to it. It's a great listen for a run, for time in the car whenever you want. And if you are going to be in Nashville this next week at the Vision Source Exchange, please look me up. Would love to say hi and connect with you. If you are not going to be there this time, look forward to connecting with you at a future event and appreciate you listening. Thanks for now.